Okay, my name is Stefani Polifrone. I have a master's in science in occupational therapy, and I'm a registered and licensed occupational therapist. I work at, I've been clinically experienced for 5 years, 4 years in the place that I currently work. It's a level 2 trauma center in the suburb of New York City. So I'm in northern New Jersey, but the suburb of New York. So we're a certified stroke center and a trauma center, as I said. We treat, it's an urban population, so we treat a lot of underserved, underinsured populations with mostly or at least the population that most of the OTs are treating are stroke, traumatic brain injury, and then other orthopedic related traumas. Our caseload plummeted because we really had a scarcity of the personal protective equipment, as with most of the facilities in the country. And it was more important that with what resources we had at the time, that the nurses be able to safely go into the patient rooms. And now that supplies have started to pick up, we are starting to treat these patients, especially now that the more critical ones have been extubated and are more stable and appropriate to participate in therapy. However, in that time, a lot of us were starting to get a little creative we obviously saw with a respiratory issue, there's a great need for therapy services. So we advocated to our supervisor about the need for putting patients in prone position. And she brought that to some of the intensivists, the directors of the ICU, who were totally on board. So when we weren't treating these patients as therapists, we were working as an extension of nursing to put the patients in prone and flip them back into supine every day as was clinically indicated. We have sometimes the intensivist will come in with us, but typically it's the bedside nurse, an advanced practice nurse, a couple of PTs and OTs, depending on the day, the distribution will be different, and a respiratory therapist. They usually leave them overnight. I think it's about 16 hours on their stomachs, and then the remaining hours of the day. Usually during the daytime, they're on their backs. We're mostly treating them as we would an acute respiratory failure patient. So we're really working on activity tolerance, teaching breathing techniques, so diaphragmatic breathing, deep breathing exercises, pursed lip breathing, and just building their tolerance to engage with the therapy sessions. So lots of vital sign monitoring and edge of bed activity at first. A lot of the therapists in the department have taken it upon ourselves to seek out continuing education resources, learn a little bit more about ventilators and stuff like that. So we've been trying to do our best to deliver as best practice as the literature is available to these patients. I scoured a lot of the AOTA literature. It seems like APTA has a lot out there as well. And there was a class, I forget what platform it was hosted on, but it was all about the ventilator and treating the ventilator. And all of us have found that to be really invaluable. Even those of us who have been working in the ICU, we were like, wow, I learned a whole lot. So I could definitely send it to you. I think it's been super interesting to watch these patients' O2 saturations, because they'll be chatting with us, they say they feel fine, and then you check their pulse ox and it's 76%. And we've been really watching a lot of that, and it's been interesting to see how the traditional respiratory failure patient would be in distress at that point, and they're just talking and feeling great. Also clinically, I've found it to be interesting. There's been a lot of, it looks like critical illness myopathy, that the patients are really proximally weak, but in compounded with the idea that they seem to have motor planning issues that I hadn't expected to see. So they can move all of their muscles, but then when you tell them bend your elbow, they can't figure out how to coordinate it. So that's been something that I've found to be super interesting, and I've found that to be a really huge thing for us OTs to be getting involved in, where I don't know if this is everywhere, but in the hospital, they tend to go PT, PT, PT for all of the patients, and then people have to start to advocate for the role of OT. And that's where we've found ourselves pushing ourselves in the door. Like, these patients can't pick up their arms and feed themselves, and this is a huge issue because they can't figure out how to move their body. So I think that's a place where OTs can find themselves, especially in settings where it is more referral based rather than in a skilled nursing facility where everybody gets therapy. I've found that where my sessions would probably have been a half hour-ish long, if not longer, if the patient could tolerate, they're really only tolerating 10 to 15 minutes. Like, well, I had a patient today at the edge of the bed, and after 10 minutes, he was like, I really want to do more. I can't. And I was like, that's fair. I completely understand. But they really do have a severely diminished activity tolerance. And obviously they've sustained prolonged intubation and been on ventilators, and obviously still have pneumonia. So it's understandable, but it's more profound than I've personally seen with other respiratory illnesses. They've been really good about iPads. So our patient relations department, I think they received a donation in addition to what they already had. So they've been going around from room to room and allowing the patients to FaceTime with their family members, which has been super nice. We've facilitated it as well. Just whenever we're in the room, if the patient has a cell phone at their bedside, we'll help them dial so that way they can talk to their family members. But it's very hard for everybody because we know how important it is to have the loved ones at their bedside, especially when you're not feeling well. So we do spend a little bit, probably more time, unbillable time, just chatting with the patient, making sure they're comfortable, making sure that they feel that human connection, in addition to just the hospital doing what they can to get people in contact. We still have a huge majority in the hospital, but people are definitely being discharged. They play a little tune over the loudspeaker every time a COVID patient gets discharged. So I hear it all day long. So people are going somewhere. I think the majority of the people who we've had on therapy caseload have been discharged to skilled nursing. And those that are still hanging out that need it, it's just because of an absence of beds at the skilled nursing facilities in the area. Although I have seen some go home. Speak up. Speak up for what you think your patients need. Keep your critical thinking hat on, I guess, because we do really see a lot that maybe the physicians aren't seeing because they're in and out of the rooms pretty quickly, or the nurses are in and out of the rooms really quickly. We're spending a little bit more of a sustained amount of time, and we may see something that's valuable to help better understand what the disease process is like. And also, we're just advocating for our patients as humans.